The abducent nerve, also known as cranial nerve 6, is a purely motor nerve responsible for innervating the lateral rectus muscle, enabling abduction of the eye. Its long intracranial course makes it particularly vulnerable to pathology. Originating from the abducent nucleus in the dorsal pons, at the level of the facial colliculus, the nerve emerges at the pontomedullary junction. From here, it begins a steep ascent, traveling anteriorly through the prepontine cistern. This subarachnoid segment is important surgically, especially in skull base approaches, as it's situated between the pons and the clivus. The nerve then pierces the dura at the clivus, entering Dorello's canal, a fibrous canal bordered by the petrous apex and the Gruber ligament. This region is clinically important because it's a common site of entrapment in cases of increased intracranial pressure or inflammatory processes like petrous apicitis. Exiting Dorello's canal, the nerve enters the cavernous sinus, where it lies medially to the internal carotid artery and lateral to the sphenoid body. Within the sinus, it travels alongside cranial nerves 3, 4, V1, and V2, but it remains distinct in its inframedial position. Any pathology here, aneurysms, tumors, or cavernous sinus thrombosis, can cause isolated sixth nerve palsy due to its exposed location. From the cavernous sinus, the abducent nerve enters the orbit via the superior orbital fissure within the common tendinous ring, and finally innervates the lateral rectus muscle. In ENT and skull base surgery, understanding this force is vital. During transclival approaches or petrosectomy, inadvertent damage to the nerve can result in a debilitating sixth nerve palsy. Additionally, pathologies such as nasopharyngeal carcinoma, petroclival meningiomas, and invasive fungal sinusitis can directly involve the abducent nerve along its course. A classic clinical correlation is Gradinego's syndrome, characterized by sixth nerve palsy, retroorbital pain due to trigeminal involvement, and otorrhea, arising from petrous apex infections. This underlines the nerve's significance in both otologic and skull-based pathologies. Finally, due to its sensitivity to intracranial pressure, bilateral sixth nerve palsies are often early indicators of raised ICP, a crucial point in emergency neurotology and neurosurgical assessments. In summary, the abducent nerve's long and tortuous pathway through the brainstem, skull base, and orbit makes it a vital structure in both diagnostic and surgical ENT contexts. Accurate anatomical knowledge ensures safer skull base access and better postoperative outcomes.